Welcome to the Rad-On Smart Review GU Cancer series.
Episode 7, Prostate, Pelvic Nodes, High-Risk Intensification, and Planning.
So for those of you listening, our earlier episodes in this series covered dose, fractionation, imaging modalities, and, the incredibly complex intricacies of androgen deprivation therapy, or ADT.
Right, but we purposefully deferred one of the absolute biggest intact prostate management decisions.
Yeah, the core question, which is essentially, should you or should you not treat the pelvic lymph nodes electively?
It's the question that has haunted tumor boards for decades, honestly.
Yeah, absolutely. I mean, if you went to national meetings 5 or 10 years ago, this was arguably one of the most hotly debated, fiercely contested questions in all of radiation oncology.
You'd see these brilliant, world-renowned attendings standing at the microphones, arguing passionately on both sides of the aisle.
Exactly. One side arguing for the necessity of regional control, and the other side arguing against, well, unnecessary toxicity.
Right. And now, recent data, specifically the POP-RT trial, which we are going to tear apart today, has significantly narrowed that debate.
But, even with that robust new data, the current American Urological Association and ASTRO guidelines still frame pelvinodal radiation as something clinicians may offer for high-risk disease. It isn't written as a universal ironclad mandate.
Which is exactly why we're dedicating an entire comprehensive session to this single topic today. Understanding why those earlier historical trials were so hopelessly ambiguous and what POP-RT finally managed to demonstrate is absolutely essential.
Yeah. We aren't just teaching this so you can pass your oral boards, though,
Yeah.
you absolutely will need to know this for the boards.
Definitely.
We're teaching this so you can be a safe, effective, and thoughtful clinical radiation oncologist.
Right. So we're going to unpack the clinical logic from the ground up. Like, when should whole pelvis radiation therapy even enter your clinical thought process?
We'll dive into the risk estimation, the biological role of modern molecular imaging, and the landmark trials that dragged us to where we are today.
And we'll also detail the modern nodal target concepts. What specific anatomical lymphatic basins do we include?
Right, and how do you actually find them on a computed tomography or CT scan? And crucially, how does a PSMA PET scan fundamentally change the entire conversation?
Exactly. And then we'll translate all of that high-risk biology into actual simulation, contouring, and boost strategies, the practical day-to-day decisions that make a truly great, robust radiation plan.
It's the strategy before the execution.
It is. So to ground this entire strategy, let's start with our case anchor. We need some clinical context.
Okay, let's lay out the specifics for the residents to jot down. You were seeing a 64-year-old man with very high-risk prostate cancer.
Okay.
He has clinical T3B disease. That means there is frank, visible seminal vesicle invasion on his high-resolution magnetic resonance imaging, or MRI.
Right, you can clearly see the T2 dark signal replacing the normal bright fluid in the seminal vesicles.
Exactly. And his prostate-specific antigen, the PSA, is elevated at 32. He is grade group 5, specifically Gleason 4 plus 5, in 10 of his 12 biopsy cores.
Wow. High volume.
Yeah. He is referred to you for definitive external beam radiation therapy, or EBRT.
And importantly, he has been properly staged with modern molecular imaging, right?
Yes, he had a PSMA PET scan. The PSMA PET shows intense prostatic uptake involving both lobes, and it confirmed that seminal vesicle extension.
But the nodes.
However, it is definitively negative for any nodal or distant metastatic disease. He's otherwise healthy, with excellent performance status and no significant medical comorbidities.
Okay, so the referring urologist is asking, are you going to treat just the prostate or the whole pelvis? And how do you decide?
That's the million-dollar question.
It is. So before we break down the why and the how, let's model exactly how you as a resident should present this patient in an oral board scenario.
Right, because when you're sitting in that exam room sweating under the lights, you want to be concise.
Exactly. Authoritative. You need to immediately show the examiner that you grasp the core clinical dilemma. So here is the canned 60-second board script you should have completely memorized for this exact scenario.
I am ready. Let's hear the gold standard answer.
Okay, I would state, this is a 64-year-old with very high-risk prostate cancer, T3B, PSA 32, grade group 5, high-volume disease with a negative PSMA PET for metastases. He will receive definitive EBRT with long-term ADT of 24 to 36 months. The nodal question is whether to include elective whole pelvis radiation. His estimated lymph node risk by the Roche formula, 2/3 times PSA plus Gleason minus 6 times 10, calculates to approximately 51%. The POP-RT trial demonstrated that whole pelvis RT improved 5-year biochemical failure-free survival, distant metastasis-free survival, and disease-free survival in high and very high-risk patients, with a Roche estimated nodal risk of 20% or greater. For boards, I must know the Roche formula, the POP-RT results, why RTOG 9413 and GTUG01 were ambiguous, and that elective nodal coverage includes the obturator, internal iliac, external iliac, presacral, and distal common iliac basins.
Man, that is absolutely textbook.
Thank you.
I mean, it hits the staging, the systemic therapy backbone, the exact mathematical risk, the landmark trial justification, and the precise anatomical targets, all in one single coherent breath.
Exactly. If you can spit that out smoothly, you've essentially already passed the station.
But, to actually understand it, we need to unpack the biology. Why does the urologist's question matter so much from a biological and epidemiological perspective?
Yeah.
Let's talk about the anatomy of spread.
It matters deeply because of how prostate cancer actually behaves and disseminates in the human body. This is a disease that spreads to the pelvic lymph nodes in a highly predictable, stepwise, dose-dependent relationship with the clinical risk group.
Right.
It doesn't just randomly pop up in the lungs or the bones without a biological pathway.
Right. It isn't random. There's a sequence to the chaos.
Exactly. The lymphatic drainage of the prostate is well documented. The primary landing zone is typically the obturator nodes, followed closely by the internal iliac nodes. From there, it marches up to the external iliacs, then to the common iliacs, and eventually into the para-aortic chains.
Makes sense.
So, for a patient with truly low-risk disease, say a PSA of 4 and a Gleason 6, the probability of microscopic nodal involvement is exceedingly low, generally well below 5%.
Yeah, in that scenario, elective nodal irradiation is absolutely not indicated. You'd just be exposing the patient's small bowel and bladder to unnecessary toxicity for zero oncologic gain.
Exactly. And for favorable intermediate risk disease, the risk remains quite low as well.
But as you cross that threshold into unfavorable intermediate high, and especially very high-risk disease like our case anchor, the biology shifts dramatically.
It does. The estimated nodal risk climbs almost exponentially. And suddenly, the question of whether treating those microscopic, clinically negative nodes actually prevents a distant failure becomes incredibly consequential.
Right. And for decades, before the era of widespread advanced MRI and PSMA PET scans, the way we quantified that invisible risk was with the Roche formula.
Oh, yes, the Roche formula.
This is an absolute classic tool in our field, developed by Dr. Mac Roche. Let's talk about how Mac Roche actually came up with this, because I think residents often just memorize the formula without really understanding where it came from. It wasn't just pulled out of thin air.
No, not at all. It was derived retrospectively from large cohorts of patients who underwent radical prostatectomies with extensive surgical pelvic lymph node dissections back in the late 80s and early 90s.
Okay.
The pathologists would meticulously examine those surgically removed lymph nodes. By looking at who actually had positive nodes pathologically under the microscope, Dr. Roche and his team reverse-engineered a mathematical formula based solely on the pre-operative clinical factors they had available.
Which were the PSA and the Gleason score.
Exactly.
It's brilliant in its simplicity. Let's walk through the calculation exactly, because as a resident, you will absolutely be expected to do this math in your head or on a scratch pad during the exam.
Oh, without a doubt. The examiner might just hand you the PSA and the Gleason and stare at you until you give them a percentage. Yes, you must know this cold. The formula is lymph node risk equals 2/3 times PSA plus Gleason score minus 6 times 10.
Okay, let's apply it step by step to our 64-year-old case anchor so the listener can follow along.
Perfect.
We take 2/3 times his PSA of 32. 2/3 of 32 is 21.3.
Okay.
Then we take his Gleason score, which is 9. We subtract 6, because Gleason 6 is essentially the baseline for this formula. 9 minus 6 equals 3.
Right.
We multiply that 3 times 10, which gives us 30. Finally, we add those two components together. 21.3 plus 30 equals approximately 51%.
Wow. A 51% estimated risk of harboring microscopic nodal disease despite having a completely negative PSMA PET scan.
Yeah.
That is a staggering number when you stop and really think about the clinical implications. It means there is essentially a coin flip that this patient already has clusters of cancer cells sitting in his obturator or internal iliac chains just waiting to grow.
Right. Now, I do want to offer a little bit of pushback here, or at least inject some modern nuance. I'll play the devil's advocate for a second.
Sure, go for it.
The Roche formula is an incredible historical framing tool. In most clinics, A calculated risk of 15 to 20% is the typical threshold where the conversation about whole pelvis radiation begins.
Right.
But isn't it true that the Roche formula is a bit of a dinosaur? I mean, it lumps all Gleason 9s together. It doesn't care if the patient has one positive core or 12 positive cores. Shouldn't we be relying on more modern nomograms like the Memorial Sloan Kettering Cancer Center, the MSKCC nomogram, or the Briganti nomogram?
That is an incredibly valid pushback, and you are absolutely right. The Roche formula is a continuous variable that we try to force into a dichotomous yes or no decision, and it does lack the granularity of modern tools.
Yeah.
The MSKCC nomogram, for example, is a much more sophisticated multivariable prediction tool. It incorporates the clinical T stage, the exact PSA value, the primary and secondary Gleason patterns independently, and the percentage of positive biopsy cores.
Which makes a huge difference.
A massive difference. If a patient has a Gleason 9 but only in 5% of one core versus a patient with a Gleason 9 in 100% of all 12 cores, the modern nomograms will give you vastly different nodal risk estimations.
Well, the Roche formula would treat them exactly the same.
Exactly.
Right, so why do we still beat the drum of the Roche formula so hard for the oral boards?
Because of the trial literature. For the purposes of rapid clinical framing, and certainly for interpreting the cooperative group trials, the Roche formula remains the lingua franca of radiation oncology.
Okay, I see.
It's the language that the trial designers used for their inclusion criteria. If you don't know the Roche formula, you simply can't understand the inclusion criteria of the landmark trials.
That makes perfect sense. Which brings us perfectly to the next logical question. We know our patient has a 51% risk of microscopic nodal disease. But the historical fundamental question has always been, does actually blasting those nodes with radiation improve the patient's survival? Or does it just guarantee them chronic diarrhea and urinary frequency?
Right.
Let's talk about the evolution of the evidence.
To answer that, we have to look at the three major randomized trials that define this space. And the key teaching point for you as a resident is understanding exactly why the first two trials failed to give us a clear answer and why the third trial finally broke through the noise.
Let's start with the spectacular failures, or the ambiguous predecessors. The first massive attempt was RTOG 9413. Walk me through the design of this trial.
RTOG 9413 was a truly massive undertaking launched in the mid-90s. It enrolled 1,323 men. The inclusion criteria required an estimated lymph node risk of greater than or equal to 15%, calculated specifically by the Roche formula. The trial utilized a complex 2x2 factorial design.
Okay, let's break down what a 2x2 factorial design actually means in this context, because statistics can get murky really quickly.
Sure. A 2x2 factorial design means the investigators were trying to answer two entirely different questions simultaneously.
Right.
The first randomization was the radiation field, whole pelvis radiation versus prostate-only radiation. The second randomization was hormone timing, neoadjuvant and concurrent ADT versus adjuvant ADT. So patients were randomized into one of four possible combinations.
Wait, hold on. Why did they think the timing of the androgen deprivation therapy mattered so much in relation to the radiation field? What was the biological theory there?
The prevailing theory at the time was radiosensitization. Androgens drive the cellular machinery of prostate cancer, including DNA repair mechanisms.
Oh, okay.
The thought was that if you gave neoadjuvant ADT for a few months prior to radiation, you would shrink the tumor, induce apoptosis, and critically impair the cancer cell's ability to repair the double-strand DNA breaks caused by the subsequent radiation.
Ah, I see.
They hypothesized that combining this neoadjuvant sensitization with a broader radiation field covering the nodes would yield a synergistic compounded benefit.
That sounds great in theory, but what about the actual radiation doses they delivered?
That is where the profound problems begin. The definitive prostate dose was only 70.2 gray. The whole pelvis elective dose was 50.4 gray.
Okay, 70.2 grays, let's pause there. In the modern era of dose escalation, we consider 70.2 gray to be a glaringly, almost unethically inadequate dose for definitive treatment of intact high-risk prostate cancer.
Absolutely.
We routinely go to 78, 80, or even 81 gray with conventional fractionation. So right off the bat, the local control in the prostate gland itself was severely compromised.
Exactly. And this is a fundamental principle of oncology. You cannot possibly demonstrate a metastasis-free survival benefit from elective pelvic nodal treatment if the primary tumor in the prostate is still actively pumping out metastatic cells because it was underdosed.
Right. If the house is still on fire, watering the lawn doesn't save the property.
I love that analogy. It's so true. But that wasn't the only issue with 9413. Let's talk about their definition of whole pelvis.
Right.
The definition of the whole pelvis field was surprisingly inconsistent and, frankly, inadequate by modern standards. Many patients actually receive what we would now call a mini pelvis field.
Mini pelvis field.
Yeah, the superior border was often placed far too low, frequently around the bottom of the sacroiliac joints. This effectively missed the common iliacs and the higher nodal basins where microscopic disease often harbors in high-risk patients.
So they underdosed the primary tumor, and they geographically missed the higher echelon lymph nodes.
Exact.
And then there's the ADT sequencing interaction. This is where the statistics get incredibly messy, right?
Incredibly messy. At 4 years of follow-up, the whole pelvis arm actually showed a statistically significant improved progression-free survival, 54% versus 47%. People were excited. But as the data matured out to 10 years, that benefit seemingly vanished into a bizarre four-arm statistical interaction. Whole pelvis radiation only appeared beneficial when combined with neoadjuvant and concurrent ADT.
And the other arms?
Paradoxically, the prostate-only arm performed incredibly well when combined with adjuvant ADT.
Which makes zero intuitive biological sense.
Mm-hmm.
Why would treating a smaller volume of tissue be superior when you give the hormone therapy later?
Exactly.
It was a statistical anomaly driven by the fact that the trial was fundamentally not powered to compare all four arms independently over a 10-year horizon. There were too many confounding variables.
Right.
So RTOG 9413 ends up being a historic milestone, but ultimately it was hopelessly ambiguous for guiding modern practice.
Which brings us to the second major attempt, the French trial, GETUG-01.
The French trial.
Yes, this trial, initiated a bit later, randomized 444 men to prostate-only radiation, receiving 66 to 70 gray versus whole pelvis radiation, delivering 46 gray to the nodes plus a standard prostate boost.
And the result of the French trial?
Completely, definitively negative. No improvement whatsoever in 5-year progression-free survival or overall survival.
So if you were a resident just skimming the abstract on PubMed, you might think, well, the debate is settled. Whole pelvis radiation is dead. It doesn't work.
Sure.
But let's look under the hood. Why did GETUG-01 fail so miserably?
Patient selection. Nearly 50% of the patients enrolled in GETUG-01 had a Gleason score below 7.
Wow. Let's really emphasize that for the listener. A Gleason below 7 means Gleason 6. That is grade group 1 disease.
Exactly. The nodal risk for a Gleason 6 population is microscopically low, well under 5%. They fundamentally enrolled the wrong risk population to answer the question. If there is no microscopic disease in the lymph nodes to begin with, irradiating them cannot possibly provide a survival benefit. You are just irradiating healthy bowel for no reason.
It's like doing a trial on a new parachute design. But half your test subjects are just jumping off a park bench instead of an airplane?
Right.
The results are going to be completely skewed. And furthermore, their pelvic field was even smaller than 9413, wasn't it?
It was tiny. Their superior border was often placed at the S1 to S2 interspace.
S1 to S2. Let's visualize that anatomically. That is barely covering the internal iliacs, and it completely misses the bulk of the external iliacs and all of the common iliacs.
Yeah.
So they enrolled patients who likely didn't have nodal disease, and for the unfortunate few who actually did, they almost certainly missed the nodes geometrically because the radiation field was drastically too small.
Precisely. The trial was statistically and biologically destined to be negative from the moment the protocol was written.
Okay, so that is the frustrating, muddy history. A massive trial with confounding hormone interactions and inadequate doses, and a French trial that enrolled the wrong patients with tiny fields. That sets the stage perfectly for the absolute game changer, the POP-RT trial.
POP-RT is the trial that finally brought clarity to this chaotic space.
Yeah.
It randomized 224 men with high and very high-risk prostate cancer. Their inclusion criteria were strict. It required a Roche estimated lymph node risk of greater than or equal to 20%.
So already we are dealing with a much higher baseline risk population than the previous trials.
Significantly higher. In fact, 55% of the patients in POP-RT had a Roche risk greater than 35%. Compare that to 9413, where only roughly 25% of patients had a risk that high.
Huge difference.
Over 90% of the POP-RT cohort had a Gleason score of 7 to 10, with nearly half having Gleason 8 to 10.
They finally found the right population. But what about the staging? This is where the POP-RT trial gets incredibly modern and relevant to today's practice.
This is the crucial differentiator. Approximately 80% of the patients in the POP-RT trial were staged upfront with a PSMA PET scan.
Let's stop and think about what that means. We are talking about a population that is clinically and biochemically at extremely high risk based on their PSA and biopsies, but we have advanced, highly sensitive molecular imaging proving that they do not have visible macrometastatic nodal disease.
Right.
They are truly N0 on the most sensitive scan we possess.
Correct. Both arms in the trial received long-term ADT of at least 24 months, standardizing the systemic therapy backbone. The radiation was delivered using modern hypofractionation techniques. They delivered 68 gray in 25 fractions to the prostate.
Let's do the radiobiology math on that for the residents. 68 gray divided by 25 fractions equals 2.72 gray per fraction.
Right.
Using an alpha-beta ratio of 1.5 for prostate cancer, the biologically effective dose, or BED, and the equivalent dose in 2 gray fractions, the EQD2, is well over 80 gray. So they absolutely delivered a modern, dose-escalated ablative dose to the primary tumor. They solved the local control problem that plagued 9413.
They absolutely did. And for the experimental whole pelvis arm, they delivered a simultaneous integrated boost, or SIB, of 50 gray to the elective pelvic nodes.
Let's explain SIB really quickly. Instead of treating the whole pelvis to 50 gray, stopping, and then doing a sequential boost just to the prostate for another several weeks, the simultaneous integrated boost uses intensity-modulated radiation therapy, or IMRT, or volumetric modulated arc therapy, VMAT, to deliver 2.72 gray to the prostate and 2.0 gray to the nodes every single day at the same time.
It's highly efficient.
Yeah, it creates a beautifully conformal dose gradient.
And crucially, geometrically, they moved the superior border of the nodal field all the way up to the common iliacs.
So they asked the exact right question in the exact right high-risk patients with modern molecular imaging, adequate ablative doses, and appropriate anatomical coverage. So what were the actual results?
The results were a resounding, unambiguous win for whole pelvis radiation. At 5 years of follow-up, the biochemical failure-free survival was 95% in the whole pelvis arm compared to a mere 81% in the prostate-only arm.
Wow.
Disease-free survival was 90% versus 77%, and distant metastasis-free survival was 96% versus 89%.
Those are massive, clinically meaningful, absolute benefits. We're talking about preventing distant bone metastases in almost 1 out of every 10 men treated. And the anatomical patterns of failure tell the whole biological story, don't they?
They absolutely do. This is the smoking gun. In the prostate-only arm, 52% of the clinical recurrences involved the pelvic lymph nodes. Let me repeat that for the listener. Over half the failures were located exactly where the radiation was intentionally not given.
Unbelievable.
In the whole pelvis arm, pelvic node recurrences plummeted to just 13%.
Now, I have to play the skeptic again. There is one major caveat that we must mention, and it is the primary reason the AUA and ASTRO guidelines still use the soft language of may offer instead of must offer. What about overall survival?
You are correct. At the 5-year mark, there was absolutely no statistically significant difference in overall survival between the two arms. It was 93% versus 91%.
Which, if you understand the natural history of prostate cancer, is completely expected at just 5 years. Prostate cancer is typically a slow-moving beast.
Right.
These patients who recur will receive multiple lines of aggressive salvage therapies. They will get novel second-generation anti-androgens like enzalutamide. They will get docetaxel chemotherapy. They will get radium-223 or lutetium PSMA radioligand therapy.
Exactly.
Because of all these rescue therapies, it often takes 15 to 20 years to show a true overall survival benefit in localized prostate cancer trials. But preventing a distant metastasis at 5 years is a massive, undeniable win for the patient's quality of life.
Now, I want to go back to a point you made a few minutes ago about the PSMA PET staging in the POP-RT trial, because I have heard residents get incredibly confused by this on the clinic floor.
Yeah.
They look at the scan and ask, if the PSMA PET scan is totally negative, why are we treating the lymph nodes? Doesn't a negative scan mean the nodes are clear?
It is a totally understandable question. It feels counterintuitive to radiate something that looks normal.
Hmm.
I think it requires a really solid visual analogy.
Okay, let's hear it.
Think of a negative PSMA PET scan in a very high-risk patient, like looking out at a freshly mowed, perfectly green lawn. Just because you don't see any full-grown, flowering weeds, which represent macrometastases, it doesn't mean the microscopic weed seeds aren't hiding right there in the soil, ready to sprout after the next rain.
That is exactly the right way to think about it.
The PSMA PET scan is an incredible piece of medical technology, far superior to conventional CT or bone scans. But its absolute lower limit of spatial resolution and detection is still a tumor deposit of roughly 2 to 4 millimeters in diameter.
Right.
Billions upon millions of aggressive cancer cells can exist in a cluster below that 2 millimeter threshold. It won't light up on a PET scan, but the cancer is undeniably there.
Absolutely.
So when a very high-risk patient has a completely negative PSMA PET, it actually provides you with the perfect therapeutic window of opportunity. It confirms that the disease has not yet exploded into bulky, uncontrollable macrometastases.
Which is great news.
That is exactly when a broad-spectrum weed killer, which in our case is elective whole-pelvis radiation, adds the absolute most value. You are sterilizing the soil. You are eradicating the seeds before they have a chance to sprout and spread to the bones.
That analogy perfectly captures the underlying radiobiology. If the PET scan is already positive with a bright, glowing lymph node, the weed has already grown. You are no longer doing elective or prophylactic treatment. You are doing directed salvage or metastasis-directed therapy. The negative scan in a high-risk patient is exactly what gives you the clinical mandate for prophylactic whole pelvis radiation.
Okay, let's transition to the clinical application. How do we take all this incredibly dense historical trial data from 9413, GETUG, and POP-RT and translate it into an everyday, easy-to-use, if-then clinical algorithm? Let's build what we call the risk ladder.
We build a ladder based directly on the National Comprehensive Cancer Network, or NCCN, risk groups. Let's start at the very bottom rung. If the patient has low risk or favorable intermediate risk disease, say a Gleason 3 plus 4 with a low PSA, then the decision tree is simple. Prostate only.
No elective nodal coverage.
Exactly. The estimated nodal risk is far below 5%. The added gastrointestinal and genitourinary toxicity simply cannot be justified by any metric.
Agreed. The toxicity profile of irradiating the bowel and bladder is real, and we absolutely do not expose favorable risk patients to it. Moving up one rung. Unfavorable intermediate risk. What do we do here?
This is where the water gets murky. For unfavorable intermediate risk, you treat the prostate plus the proximal seminal vesicles. But whole pelvis radiation is a highly individualized clinical decision. It is generally based on the Roche estimated nodal risk crossing that 15 to 20% threshold, or a similar calculation from the MSKC nomogram. You sit down with the patient, explain the pros and cons, and make a shared decision.
It's worth mentioning for the listeners that we actually have some very early data trying to answer this specific rung of the ladder. RTOG-0924 is a massive trial that randomized unfavorable, intermediate, and favorable high-risk patients to prostate and seminal vesicles alone versus whole pelvis radiation.
Right.
They reported early interim results at the ASTRO annual meeting recently, and so far, there's no overall survival advantage at the current follow-up.
Which perfectly reinforces our main point. The benefit of pelvic radiation is entirely dependent on stringent patient selection and reaching a high enough baseline risk level. Which brings us to the next clear rung. High risk.
If the patient is true high risk, meaning clinical T3A or grade group 4 or a PSA greater than 20, then you are definitively treating the prostate plus the seminal vesicles, and whole pelvis radiation should be strongly considered.
Yep.
If their Roche score is greater than or equal to 20%, the POP-RT trial gives you direct, randomized, level 1 evidence to support your whole pelvis treatment recommendation. And of course, long-term ADT is the mandatory systemic partner here, as we discussed extensively in episode 6.
Then we reach the very top of the intact disease risk ladder. Very high risk. This represents our 64-year-old case anchor.
Right. Clinical T3B, or grade group 5, or multiple high-risk features stacked on top of each other.
For these patients, whole pelvis radiation with prostate and full seminal vesicle coverage is overwhelmingly favored in modern practice. The microscopic nodal risk is simply too immense to ignore. They require long-term ADT, typically a duration of 24 to 36 months. Furthermore, you must also consider the STAMPEDE trial criteria for systemic intensification. That means adding an androgen receptor pathway inhibitor, or ARPI, like abiraterone, to their hormonal backbone for 2 years.
Okay.
And finally, if their anatomy allows, meaning they have a good baseline urinary function and no severe pubic arch interference, you strongly consider a brachytherapy boost for maximal local dose escalation, as we covered in episode 5.
I'm glad you brought up brachytherapy. The inverse square law of physics dictates that with radioactive seeds, or a high-dose rate source placed directly inside the prostate, you can deliver astronomical doses to the tumor while exquisitely sparing the adjacent rectum.
Oh, yeah.
But that's a topic for another day. Finally, what if the patient is actually node positive, or N1, on their staging imaging?
If they are clinically N1, the entire paradigm shifts. It is no longer an elective discussion, it is a directed treatment. Whole pelvis radiation plus long-term ADT is the guideline-supported curative intent management. RTOG 8531 showed massive overall survival, biochemical, and distant metastasis benefits from adding ADT to radiation in node-positive disease. The 9-year overall survival in that older trial was 62% with hormones versus 38% without.
Wow.
And modern data from the STAMPEDE radiation comparison robustly supports radiating both the prostate and the whole pelvis in regional N1 disease. You are still aggressively playing for a cure.
That risk ladder is incredibly helpful to conceptualize. But deciding to treat the pelvis is really only half the battle. Now you actually have to sit at the computer, execute the plan safely, and not wreck the patient's quality of life.
So true.
That brings us to treatment techniques and target volumes. We have decided to treat the whole pelvis for our 64-year-old case anchor. How do we literally draw it on the CT scan, and how do we plan it safely?
Let's start with the gross anatomy. What exactly goes into the modern elective nodal clinical target volume, the CTV? There are 5 distinct lymphatic basin groups that you absolutely must include.
And to remember them, I always teach my residents a simple mnemonic. Oh, I expect perfect coverage.
That is a great memory aid. Let's spell it out clearly. O stands for the obturator nodes, which sit right along the pelvic sidewall.
Okay.
I stands for the internal iliac nodes, which are also known historically as the hypogastric nodes. Expect stands for the external iliac nodes, following those main vessels down to the groin.
Right.
Perfect stands for the presacral nodes, sitting right in the hollow of the sacrum. And coverage stands for the common iliac nodes, specifically the distal portion.
Oh, I expect perfect coverage. Obturator, internal, external, presacral, common iliac. So we know the names of the basins, but where do we actually set the geometric borders when we are clicking the mouse? This has evolved significantly over the last decade.
It has evolved tremendously. If you look at the classic 2009 RTOG Consensus Contouring Atlas, which is often referred to as the Lawton Atlas, they began contouring the superior border of the field at the L5S1 interspace. Geometrically, this covers the proximal presacral region and just the very distal tips of the common iliacs.
But remember our earlier discussion about why POP-RT succeeded, where the older trials failed. POP-RT used a much more modern, aggressive approach to their borders. They extended that superior border cranially to approximately the L4-L5 interspace.
Exactly. They recognized from surgical mapping data that common iliac failure patterns were highly prevalent in very high-risk disease. Extending the radiation field superiorly provides much more robust, comprehensive coverage of the common iliac vessels.
That makes a lot of sense.
That geometric difference in the CTV may absolutely be part of the reason POP-RT was overwhelmingly positive while older trials failed. For a very high-risk patient like our case anchor, extending superiorly to L4, L5, or even up to the aortic bifurcation is highly reasonable and often recommended.
Imagine scrolling down the axial CT slices from the top of the abdomen. You see the aorta split into the left and right common iliac arteries. That bifurcation is often right around L4. That's exactly where you want to start painting your nodal volume. What about the other borders?
The lateral border is defined by the external iliac vessels extending out to, but not into, the pelvic sidewall musculature, like the obturator internus. The posterior border is the presacral space, but you must take extreme care here.
Why is that?
You have to meticulously carve the target volume off the posterior structures to limit the small bowel dose. Inferiorly, the nodal CTV typically extends down to the top of the pubic symphysis or the level of the obturator foramen, and then it merges seamlessly with the prostate and seminal vesicle CTV.
Now, I want to highlight an absolutely massive contouring trap right here. This is a classic oral board trap that will instantly fail a resident if they miss it. I call it the T3B pitfall.
Oh, this is a critical one. Walk us through it.
When you are contouring the high-dose CTV for a standard intermediate risk patient, standard practice dictates that you include the prostate gland and just the proximal 1 to 2 centimeters of the seminal vesicles.
Right, because the distal tips of the vesicles are usually perfectly clean, so we spare them to save rectal dose.
Exactly. Many treatment planning systems even have auto-contouring templates that just chop off the vesicles at 1 centimeter. But if you have a T3B patient, meaning frank seminal vesicle invasion visible on MRI, you absolutely must manually contour and include the full bilateral seminal vesicles in your high-dose ablative CTV.
Yes. The anatomy of the seminal vesicles is essentially a pair of blind pouches. The cancer tracks upward from the base of the prostate along the ejaculatory ducts and can quickly permeate the entire glandular structure of both vesicles.
Right.
If you just drop a standard lazy intermediate risk template onto a T3B patient, you are committing a severe geographic miss. You are leaving known, high-grade, aggressive cancer completely outside of your ablative dose volume.
It sounds so obvious when we sit here and say it out loud in this discussion, but when you are a resident rushing through a treatment plan in a busy clinic or sweating under the intense pressure of a board examiner, it's incredibly easy to just click proximal SV out of habit and move on. You have to actively adjust your target to the patient's specific pathology.
Excellent point. So we have meticulously drawn our targets. Now we have to talk about the physics and the functional trade-offs. What is the actual human cost of treating all of this extra pelvic real estate?
The dominant quality of life trade-off is gastrointestinal and genitourinary toxicity versus oncologic nodal control. When you expand your field to include the whole pelvis up to L4, you are drastically increasing the irradiated volume of the small bowel, the sigmoid colon, and the superior dome of the bladder.
Yeah.
These are the primary dosimetric drivers of late diarrhea, bleeding, and urinary frequency.
And we saw this exact trade-off in the POP RT safety data. They reported a slight but measurable increase in late grade 2 plus GU toxicity, 31% in the whole pelvis arm versus 23% in the prostate-only arm. Fortunately, severe grade 3 toxicity was rare in both arms, hovering around just 5%.
So if we accept as clinicians that there is a toxicity cost to curing the cancer, our job as radiation oncologists is to relentlessly, obsessively mitigate that cost through physics and setup. How do we do that? It all starts in the simulation room.
The absolute necessity of strict, reproducible simulation protocols cannot be overstated. You must have a rigorous bladder filling protocol. Typically, we aim for the patient to have 200 to 300 cc's of urine in their bladder at the time of the CT simulation.
Why is that specific volume of urine so mechanically critical? Let's visualize it.
Think of the bladder like a slowly inflating balloon pinned against the rigid pelvic floor. As it fills with urine and expands, it has nowhere to go but up and back. As it expands superiorly, it literally bulldozes the loops of small bowel up into the abdomen, physically displacing them out of your pelvic nodal CTV.
That's a great image.
Secondarily, a full bladder dilutes the radiation dose to the bladder dome itself because the surface area is stretched out. But the key word here is reproducible.
Right. What happens if it isn't reproducible? Let's say the patient drinks his water and has a beautiful 300 cc bladder at simulation, but on treatment day 4, he gets stuck in traffic, rushes in, uses the restroom, and only has 50 cc's in his bladder on the table. What happens to your beautiful plant?
It's a disaster. Without that balloon propping it up, the small bowel falls right back down deep into the true pelvis, directly into your high-dose region. Your perfectly optimized, pristine IMRT plan is now actively burning a hole in their jejunum.
Which is terrifying. And similarly, you need an empty rectum protocol, sometimes using a daily mild enema or a dedicated rectal balloon, to keep the prostate from shifting anteriorly day to day. Feces and gas can push the prostate right out of the target zone.
This differential motion between the different targets in the pelvis is exactly why daily advanced image guidance is completely non-negotiable for whole pelvis treatments.
Let's expand on the physics of that. For a simple prostate-only plan, you might just use standard planar KV imaging to line up implanted gold fiducial markers in the gland. But for a whole pelvis plan, why isn't that enough?
Fiducials are not enough because they only tell you exactly where the prostate is. But pelvic nodal anatomy shifts entirely independently of the prostate. The external iliac vessels, which guide your nodal targets, do not move when the rectum fills with gas, but the prostate
Oh,
does.
I see.
If you only align to the prostate fiducials, you might be shifting the nodal field right off the lymph nodes. You need daily cone beam computed tomography, or CBCT, to volumetrically visualize both the prostate and the entire nodal CTV simultaneously. You have to visually ensure both independent targets are safely covered every single day before you turn the beam on.
And briefly, before we move on, what about placing a hydrogel rectal spacer, like SpaceOAR, during the fiducial placement?
A rectal spacer is a fantastic tool. It creates physical hydrogel separation between the anterior rectal wall and the posterior capsule of the prostate, pushing the rectum out of the high-dose region. This allows for higher prostate doses with significantly reduced late rectal toxicity.
Okay.
It is incredibly valuable, especially for highly dose-escalated or extreme hypofractionated plans. However, for very high-risk patients with bulky posterior disease extending into Denonvillier's fascia, you have to be extremely careful not to accidentally inject the spacer directly into the tumor itself, which could push cancer cells further away or shield them.
Right, that makes sense.
It is highly individualized, but regardless, placing a spacer does not change the nodal planning parameters or the CBCT requirements we just discussed.
This has been an incredibly deep and practical discussion. Let's start to pull it all together so the listener can walk away with actionable knowledge. Here are our clinical pearls for the episode. I'll take the first one, you take the second, and we will alternate.
Sounds good. Pearl 1. The POP-RT trial is the definitive modern landmark trial for whole pelvis radiation therapy in high and very high-risk intact prostate cancer. By meticulously selecting patients with a Roche estimated risk of greater than or equal to 20% and using modern PSMA PET staging and adequate ablative primary doses, it proved once and for all that treating the pelvis dramatically reduces pelvic recurrences and improves distant metastasis-free survival.
Right.
Even though it currently lacks an overall survival benefit at 5 years, the impact on disease progression is undeniable.
Pearl 2. The classic Roche formula is an incredible historic tool to frame the clinical discussion of risk. Remember the math. 2/3 times PSA plus Gleason score minus 6 times 10.
Definitely remember the math.
But it is not a rigid, absolute binary trigger for treatment. You must combine it with modern, multivariable nomograms, the patient's specific anatomy, and your own clinical judgment. A calculated score of 19% doesn't automatically mean no, and 21% doesn't automatically mean yes. Treat the patient, not just the math.
Pearl 3. A positive PSMA PET finding in a regional pelvic lymph node does not eliminate the need for whole pelvis radiation. Instead, it entirely alters your dosimetric strategy.
Yep.
It means you must deliver a sequential or simultaneous integrated boost to that specific glowing positive node, pushing it to a higher ablative dose, while still delivering the standard lower elective dose to the remainder of the clinically negative pelvic basins in order to sterilize the invisible microscopic disease.
Excellent synthesis. Now, it is time to put the listener on the hot seat. Let's do a quick board blitz to test what we've covered. I'm going to ask the question. I want the listener to pause, think about the answer for a split second, and then you will provide the gold standard response. Ready?
I'm ready, fire away.
Question 1. You are evaluating a 67-year-old high-risk patient in clinic. His PSMA PET scan is completely negative. His calculated Roche estimated nodal risk is 37%. Based specifically on the inclusion criteria and results of the POP-RT trial, do we include whole pelvis radiation therapy? Listeners, think about it. Okay, what is the answer?
The answer is absolutely yes. The rationale and the trap the examiner is testing is that a negative PSMA PET in a high-risk patient confirms the presence of subclinical risk rather than macrometastatic disease. That subclinical state, the seeds in the soil, is exactly the scenario where elective whole pelvis radiation is indicated and proven highly effective by the POP-RT data.
Perfect. Question 2. Which specific nodal basins must be included in the standard elective pelvic CPV for a very high-risk patient? Think of the mnemonic. Okay, give it to them.
You must include the obturator, the internal iliac, the external iliac, the presacral, and the distal common iliac basins. Remember, I expect perfect coverage. If they give you a multiple-choice question, periaortic and inguinal lymph nodes are incorrect answers for standard elective coverage in prostate cancer.
Question 3. You are at the computer during whole pelvis treatment planning, and the physicist alerts you that the small bowel dose significantly exceeds your mandatory constraints. What is the single most effective clinical strategy to reduce that bowel dose without shrinking your target? Listeners, visualize the anatomy.
The most effective strategy is strictly enforcing a full bladder protocol at simulation and daily treatment. A comfortably full bladder acts as a balloon, physically displacing the small bowel superiorly and posteriorly, moving it entirely out of the high-dose nodal CTV without compromising your target coverage.
Spot on. Final question. Question 4. A junior resident is contouring the high-dose CTV for a T3B prostate cancer patient. What is the correct management of the seminal vesicles in this specific anatomical scenario? Take a second. Okay, what's the trap?
The full bilateral seminal vesicles absolutely must be included in the high-dose volume. If the resident uses a standard intermediate risk template and contours only the proximal 1 centimeter, it is a severe geographic miss that leaves gross tumor behind and will inevitably lead to a marginal recurrence.
Aced it. That brings us to our summary and outro. We have covered an immense amount of clinical, biological, and dosimetric ground today. To quickly recap, the decades-long fiery debate over whole pelvis radiation was substantially cleared up by the meticulous design of the POP-RT trial.
It was.
The key to everything we discussed today is patient selection. You cannot treat everyone, and you cannot treat no one. You must treat the right risk population, meaning a roach risk generally greater than 20%. You must cover the right anatomy, extending that superior border cranially up to L4, L5, and ensuring full seminal vesicle coverage for T3B disease. And you must use the precise right technique, utilizing IMRT or VMAT, relying on daily volumetric CBCT for differential target visualization, and adhering to strict reproducible bladder and bowel protocols.
It is a complex, multi-step workflow, but when you execute it correctly, you are fundamentally altering the natural history of a very aggressive disease. You are preventing bone metastases and buying the patient years of quality life. And looking forward, next time our focus shifts entirely to the other side of the treatment paradigm. Episode 8, Prostate, Salvage After Surgery, RT, and Focal Therapy. We look at what happens when the primary surgery fails, the PSA starts rising again, and how radiation steps in to rescue the patient.
It's going to be a fantastic, highly relevant discussion. Before we sign off, I want you to think about that negative PSMA PET scan again and the analogy of the weed seeds. If our molecular imaging technology continues to exponentially improve over the next decade, reaching a point where we can detect microscopic clusters of just a few hundred cells, will the concept of elective whole pelvis radiation disappear entirely? If we can literally see every single microscopic weed seed on a scan, do we still need to spray the whole lawn with a broad-spectrum weed killer? Or do we just precision zap the individual seeds with stereotactic radiation? It's something provocative to mull over before our next session. Complete practice oral boards at radonsmartlearn.com and subscribe to Radon Smart Review for our next episode. Thanks for tuning in.